Are you struggling to study vesiculobullous diseases, or do you keep mixing them up every single time? No matter how much you study, you still forget them? Today, we're focusing on their clinical features, so let's dive in.
You know, the key to finally getting a handle on these conditions is to stop trying to memorize them as just one long, confusing list. What we're going to do instead is build a really clear mental map. We'll break them down into 3 big categories based on what's actually causing them: viral, immunologic, and hereditary. Trust me, structuring it this way is going to make everything click. So, here's our game plan. We're going to kick things off with the viruses, then we'll move into those autoimmune conditions. After that, we'll briefly touch on the hereditary group, and then, this is the best part, we'll wrap up with a rapid-fire review to really hammer home the differences between the ones people mix up the most. All right, let's get into it. Okay, first up, the viral diseases. Now, these are, by far, the most common blistering conditions you're going to see, especially in your younger patients. They're contagious, they come on fast, and the good news is they often have really distinct clinical clues that help you figure them out.
All right, let's unpack this table. Think of this as your cheat sheet for the usual viral suspects. So, primary herpes simplex. This one hits little kids, usually under 5, and it can show up literally anywhere in the mouth, often with this really nasty full-blown gingivitis. Then you've got its cousin, secondary or recurrent herpes, which is what we see in adults. You know, the classic cold sore on the lip, or maybe some ulcers on the hard palate. And it almost always starts with that telltale tingling feeling. Next is varicella, chickenpox, another childhood classic with a rash all over the body where you can see brand new spots and old crusty ones all at the same time. When that same virus reactivates in adults, you get herpes zoster, or shingles. The key here: it's brutally painful and stays on one side of the body, following a nerve. Then we had the Coxsackie viruses, hand, foot, and mouth disease, the name tells you exactly where to look, and Herpangina, which is all about the back of the mouth. And last but not least, measles, which has a super unique sign we're going to talk about in a minute.
You know, in oral path, it often comes down to one thing: location, location, location. So if you see a child with vesicles and ulcers just everywhere, and their gums are bright red and swollen, your first thought should be primary herpes. But if those lesions are hanging out exclusively in the way back of the throat, we're talking soft palate, tonsils, that should scream Herpangina, which is caused by a totally different bug, Coxsackie virus.
This right here is such a perfect example of how one single virus, Varicella-Zoster, can cause 2 completely different diseases. Chickenpox is what you get the first time you're infected. It's that widespread itchy rash in kids where you see all the stages of the lesion at once: bumps, blisters, and scabs. So after you get over it, the virus doesn't leave. It just goes to sleep in your nerve ganglia. Then, years later, stress or a weakened immune system can wake it up, and bam, you've got shingles. It's a blistering rash that's unilateral, way more painful than itchy, and it absolutely does not cross the midline of the body.
Okay, this is one of those classic board exam facts you just have to burn into your brain. Koplik spots. They are pathognomonic for measles. What does that mean? It means if you see them, it's measles. Period. They look like tiny little grains of salt on a red background, right there on the inside of the cheek. And here's why they're so incredibly important. They show up before the famous measles skin rash, giving us a critical heads up for an early diagnosis.
All right, let's switch gears to our second category. In this group, the problem isn't some virus from the outside. Nope, here the enemy is coming from within. We're talking about autoimmune diseases, where the body's own immune system gets confused and starts attacking the very proteins that hold our skin and mucous membranes together. And the result? Blistering.
So this table sums up the big 4 autoimmune blistering diseases. Now, the absolute most important difference to get your head around is where the split in the tissue is happening. Check out Pemphigus vulgaris. Here, the split is intraepithelial, right in the middle of the skin layer itself. This creates these really fragile, saggy, or flaccid blisters that just pop super easily. Now, contrast that with mucous membrane pemphigoid and bullous pemphigoid. In both of those, the split is subepithelial, meaning the entire top layer is lifting off. This makes for much tougher, tense blisters. Also, notice that oral lesions are a huge deal in pemphigus and mucous membrane pemphigoid, but not so much in bullous pemphigoid, which tends to favor the skin. And we'll get to that cool string of pearls pattern for linear IgA disease in a sec.
Let's really drill down on this because it's so fundamental. Why are some blisters floppy and others firm? It's all about the microscopic level. In pemphigus, the body is attacking the desmosomes, the little spot welds between the skin cells. So the split happens mid-layer, leaving just a thin, flimsy roof on the blister. It just can't hold up. In pemphigoid, the attack is on the basement membrane, the foundation holding the whole epithelium down, so the entire layer of skin lifts off. That makes for a much stronger, tenser blister that can stick around longer.
And you've got to remember, this clinical pearl for Pemphigus vulgaris, first to show, last to go. For the majority of patients, the very first sign of this incredibly serious disease is going to be painful ulcers in their mouth. As dental professionals, you are on the front lines. You might be the very first person to spot this, sometimes months or even a year before any skin lesions show up. Recognizing this early is absolutely huge for the patient.
Now, while pemphigus and pemphigoid usually give us these big, ugly ulcers, linear IgA bullous disease, or LAD, often shows up with a much more artistic pattern. Patients can get these vesicles and bullae that form in circles or arcs. It's often described as a string of pearls or a crown of jewels, which gives you a really specific visual to look for that helps set it apart from the others.
Okay, on to our third and final category. This one's a group of rare inherited conditions. And while you probably won't see these every day in clinic, it's definitely important to know they exist.
This whole category is really dominated by epidermolysis bullosa, and it's not just one disease, it's actually a whole group of genetic disorders. The common thread between all of them is that the skin and mucous membranes are incredibly fragile. We're talking blisters and sores from even the slightest touch or friction. Now, because this is such a complex group of rare diseases, we're keeping our detailed comparison focused on those more common viral and immunologic conditions we've been talking about.
All right, it's time for the lightning round. Let's put some of the most frequently confused diseases side by side. This is where we're going to solidify these concepts and make sure you can tell them apart even when you're under pressure.
Let's start with the big two, pemphigus versus pemphigoid. Just remember, pemphigus is intraepithelial, which means flaccid bullae, and the mouth is often where it starts. Mucous membrane pemphigoid is subepithelial, giving you those tense bullae. And while the mouth is also a common spot, you have to worry about the eyes because scarring there can actually lead to blindness.
Next up, two viral infections that give you oral ulcers. So how do you tell them apart? It's all about the real estate. Secondary herpes loves keratinized tissue, that's the hard palate and the attached gingiva. Herpangina, which is from Coxsackia virus, is a squatter on non-keratinized tissue, way in the back, soft palate, tonsils. It's a classic diagnosis based purely on location. Okay, two diseases that make little kids absolutely miserable. The #1 giveaway for hand, foot, and mouth is right there in the name. You're going to see lesions on the hands and feet as well as in the mouth. And, super important, it usually leaves the gums alone. Primary herpes, on the other hand, is famous for causing a fiery, painful, widespread gingivitis that involves the entire mouth.
And there you have it. By breaking these diseases down into categories, viral, immunologic, and hereditary, and really focusing on those key clinical clues, you can build a mental framework that makes them so much easier to remember. I really hope this helps you finally master these conditions. For more deep dives to help you crush oral pathology, make sure you check out the Master Oral Path channel on YouTube.
All the information we covered today was put together from a bunch of great sources, including the 7th edition of Oral Pathology Clinical Pathologic Correlations and online resources from Wikipedia, Vital Record, the NHS, Healthline, and 24/7 Medcare.
So I'll leave you with one last thing to chew on. Now that you can tell these diseases apart on paper, which one do you think is actually the toughest to diagnose in a real-life clinical setting, and why? Think about symptoms that overlap, how a patient might present, and at what point a biopsy becomes non-negotiable. It's a great question to think about as you continue your studies. Thanks for tuning in.